Let's get started. Frank, welcome to our empowerment series. Thanks for joining us. This is really a good time for us to kind of educate our clients and patients about what you do, and services that our clients might utilize and want to be educated about.
Thank you.
So welcome. Yeah. So why don't we start off? Could you start us off and tell our viewers and listeners who you are and what inspired you to become a doctor of audiology?
My name is Dr. Franklin Zetta. I'm an audiologist. So what inspired me to be an audiologist? It's just simple that I'm always interested in helping people, and the gratification you get from helping someone um, reestablish their ability to hear correctly is quite gratifying. To help someone, help with, overcome to an extent their tinnitus. Is also very gratifying. So those are the things that led me toward audiology. Although other than that, it was more of a concrete type of field where do this, get this result type of thing. That's kind of like how I work. So that's why I enjoy it.
Practical. How did you get first? I know you had your bachelor's, you did your master's, and then you did your doctorate. Was there a moment in time before you got started where you're like, oh, this is actually something I'm interested in pursuing?
Yes. So when I was in college, I initially was in psychology as my major, and then I realized that I actually sat in on one of my friend's classes. It was just she was telling me about it, and I sat in on it, and it just kind of clicked, and I said, wow, this is really it's just a really interesting field, and I feel like I would do well here, and I'd be able to still help people because I wanted, as I said, I started off in psychology thinking I always wanted to be in the healthcare service helping someone. And this incorporates psychology a lot into the field, believe it or not. There's a lot of counseling that goes along with hearing, hearing loss and tinnitus and stress and anxiety that people have from these issues. So it definitely incorporates it. So it worked right into my desires.
Nice. It definitely kind of goes hand in hand with with the psychological aspect that comes with with losing your hearing all of a sudden, or not being able to kind of hear, and how detrimental it is to your life.
Yes.
Um, in simple terms, could you tell our audience about the parts that make up our ear and how we process sound?
Absolutely. Actually, I have a little model here. I don't know if it's visible,
Yep.
but the ear is essentially, this is going to be very simple. The ear is built into with three chambers, well, three parts rather. You have the outer part, the middle part, and the inner part. The outer part is the ear itself, called the pinna, and then the external auditory meatus, which is the ear canal, the tympanic membrane, which is your eardrum, and that's comprised of the outer part. The middle part are the tiny little bones called the ossicular chain, eustachian tube. The inner part is the cochlea and the eighth auditory nerve. How the whole mechanism works together is the pinna is shaped the way it is to collect sound, and it funnels the sound into the auditory canal. When it does that, it hits the eardrum. The eardrum starts to vibrate. It's actually mechanical energy. So as long as there's no issue in the middle ear, and I'll explain that in a second, the sound is then transferred across the tiny little bones into your cochlea, into the oval window. The sound is then transformed into electric acoustic energy. It goes all the way up the basilar membrane to the eighth auditory nerve to the brain. The brain is actually where we process and understand. The ear is just built to collect the sound. Now, some of the issues you can have with collecting sound is you can have a ton of wax in the auditory canal. So it's always good to have it checked. Once it's cleaned, a lot of times that can be the issue. Or in the middle ear, you can have either like a perforated eardrum, or you can have fluid in the middle ear. You can have eustachian tube dysfunction. Eustachian tube dysfunction is similar to like when you fly on a plane and you feel that pressure in your ear. That's eustachian closing and sucking the eardrum in and preventing it from vibrating the correct way, and that can actually affect the way you hear. And a lot of times people will drink or swallow or chew or do the Valsalva, where you hold your nose, close your mouth, and try to blow, and that sends positive pressure up the eustachian tube and opens them up. Sometimes people, more predominant in children, but adults too, can get fluid in the middle ear from an infection, and which will not allow sound to transmit correctly into the cochlea. So barring any issues, sound goes to the canal, hits the eardrum, transfers through the ossicular chain to the cochlea, up the eighth auditory nerve. If there's any issues in the middle or outer ear, 9 out of 10 times you can either through medication and or surgery correct the issue. If the damage is in your cochlea, unfortunately there is no medication and or surgery that will rectify that. That's where hearing devices come into play. Also, sometimes if you have what's called a conductive, which is middle, sensorineural would be cochlear related. Conductive would be outer or middle ear. Sometimes you can have what's called otosclerosis, which is a bony growth at the base of your little tiny bone here called the stapes, and it prevents the ossicular chain from vibrating into the cochlea, and that can cause hearing loss. That an operation can take care of. As I said, fluid in the middle ear, a perforated eardrum. Sometimes you have multiple ear infections which cause scarring on the eardrum, and that also can affect the way you hear. If you choose not to do surgery for, say, otosclerosis, you can get a hearing device to help, push the sound past the ossicular chain into the cochlea. Same thing for outer ear issues. Some people have what's called microtia, which is the closing of the malformation of the ear. Atresia is the closing of the canal, where sometimes their cochlea is fully intact and they can't hear because it's the canal is just not existent, or there's no ear, which happens in birth. You can get what's called bone anchored hearing aid that bypasses the outer middle ear and sends a signal right into the cochlea. So those are the different parts of the ear and how they function, and some of the remedies you can use for that.
Kind of neat. That's kind of neat. That's quite a breakdown of how we process sound, and that this is more of an auditory, and that your brain is what kind of process really the message.
Right. And what's happening is when sound can't go, if sound hits the cochlea, there's we call them hair cells. They look like hair, but they're not. And they vibrate, and sound will travel across them. So when you have cochlear damage or sensorineural damage or hearing loss, some of those hair cells start to die off and weaken, and they don't vibrate. So it's now sound has a harder time getting across. An analogy I like to use a lot with my patients is two cliffs connected by a wood planked bridge. Are you familiar with that? Have you ever seen one of those?
Yep.
Okay. Think of that bridge as the ear system, and people getting across is sound. When the bridge is fully new and all the planks are there, no issues, no problem. But when there's damage, regardless of where it is, some of those planks are now missing. The more planks are missing, the more severe the hearing loss, and the harder sound for get across. If a hearing aid is utilized, the hearing aid puts a lot of those planks back and allows sound easier time getting across. So it bypasses some of the damaged areas. So that's an analogy I like to use to explain how hearing works, and and how hearing aids can actually help replace some of those planks, and makes it easier to hear in multiple situations, also depending on the severity of the loss.
That's a great analogy. That's a great analogy of kind of think about how the passage of sound goes through that that instrument and vibrates off. So that makes a lot of sense for people who are trying to visualize in a simple terms of how sound travels, because it's not something we see.
Right. Yes. A lot of times, hearing is taken for granted in all situations, unless like the hearing aid is very visible. But then, people's reactions to hearing loss are always, what's the matter? You're not listening, or you can't hear me, or what are you deaf? And it's, the derogatory statements toward, individuals with loss. If someone had to wear a cane or a crutch, because when they had hearing loss, there's more sympathy. You can see more, more people are more ready to help that person to an extent, because they see that there's a disability. And with hearing loss, it's invisible, and a lot of the hearing devices are also invisible and not really noticeable. So people just automatically assume that, hey, you're not listening or whatever, what's going on. So yeah, it's an invisible thing. Again, it's something that people just take for granted. They think they're going to always hear, and unfortunately that's not the case.
And speaking of that, what are some of the signs that someone is losing their hearing and should have their hearing assessed and looked at?
So a lot of times the individual themselves don't realize it, because especially if it's gradual, it's over time. And so the brain helps compensate, or they compensate for themselves. For example, some people become more of a recluse. They don't like going out anymore, not because they don't enjoy the companies, because now they realize, so subconsciously they realize they're not able to follow the conversation. They don't want to admit to themselves that they have the hearing loss, but now they'll say, I don't want to go to X, Y, and Z restaurant. I don't like the food there anymore. I don't like the ambiance. But it's not that this is the case. They know when they go there, they're not able to follow the conversation, and they get frustrated by asking people to repeat themselves. Another thing is the significant other or family member a lot of times will say, hey, listen, we're having conversations, you're misunderstanding a lot what we're saying. I ask you X, Y, and Z, and you're just telling me A, B, C. Maybe you should have your hearing checked. But these are all the gradual losses. Sometimes people realize it themselves. They start to realize, oh, I don't hear as well, or, I'm raising the volume on the television or the radio, or I'm asking people to repeat themselves a lot. And that's not how it used to be. Those are indicators that should prompt you to get your hearing tested. Or if you have any type of hearing loss in the family, any genetic related, parents or aunts and uncles who might have, hearing loss, that also should prompt you to have yourself evaluated.
And then what's a simple way to quickly test one's hearing health?
Well, I mean,
This one.
Well, you can do what's called a hearing health quick test. You can look up online. It's a scale. You fill it out yourself. It has a bunch of questions. I have a copy here. And then you go through it and you answer the questions honestly. And then you look at the score at the end, and it tells you if you have this kind of score, you should have your hearing checked. If you have a 0, then you're doing well. But this is a scale that you need to really answer honestly. Some people, again, when they're not interested in getting their hearing evaluated, or they're being pushed by family members, will, be stubborn and say, no, this doesn't happen. And then when you ask questions, it's like, oh, you watch TV? Yes. Well, what's the volume? And their significant other will say, oh, I can't stay in the room. And they say, well, I hear it perfectly fine. You're not hearing it perfectly fine if your significant other or a family member can't stay in the room with you because it's too loud. But that's a quick way to do it, just a self-assessment. But there's no real quick way other than that. I mean, you contact an audiologist, set up an appointment, and have your hearing evaluated, because that's the true measure of your hearing loss. Doing it yourself, again, you might not answer the questions, truthfully, but when you do get evaluated by a professional, they're going to give you the exact results of the test you did. And we know how to get around what's called malingering, where people think it's one thing when it's another, or the false positives when they say yes when I'm not presenting. We're trained to get around all that, so we give you a true value of what your hearing is.
Sounds like you guys are much more objective.
Sorry?
And that sounds like it's much more objective than the than a survey you're filling out where it could be kind of more subjective, and
The
when someone's
survey is definitely more subjective. The hearing evaluation is more objective. Absolutely.
gotcha. And what's your take, speaking about noise-induced hearing losses, what's your take on the noise pollution, its role in the role it plays in contributing to someone's hearing loss?
So we, years ago, probably in the 50s, 40s, 30s, 20s, we didn't live, even though it's an industrial world, we didn't live as in a noisy environment. Today, we're constantly bombarded with noise everywhere: trains, cars, televisions, radios, earbuds. Listening to years ago it was a Walkman. Now it's on your phone or whatever the case may be, or MP3 player, depending on how old you are.
Right.
We're constantly being bombarded with noise. Now we have a weighting scale that allows us a certain amount of decibels. One scale says 85 decibels, and one says 90. So between 85 and 90 decibels, which is pretty loud, we're rated to listen to that sound 8 hours a day without causing damage, unless it's over longevity, which is like, maybe 10, 20 years, then you can see some damage. But that scale dramatically changes. The louder the decibels is a measure of loudness. So the louder the decibel, the shorter the amount of time you can listen to it. So say for 95 decibels, instead of 8 hours, it's 4 hours. For 100 decibels, it's 10 minutes. If 105, it's 3 minutes, so on and so forth. So the higher the decibel, the range does drastically shorten. So at 120 decibels, if you listen to it for a few seconds, it can cause damage to your hearing. 140 can cause damage to your hearing instantaneously and cause bleeding in the ears, because the eardrums can rupture from the pressure of the sound.
So for someone who works in, hypothetically speaking, the two, occupations that I can think of rarely is someone who works in construction or works under the subway.
Yeah. So for those, any type of profession where you're around loud noise, so subway worker, construction, even landscapers or carpenters or plumbers, where there's banging of hammers, power tools, anything of the sort, should be wearing hearing protection. They sell, rudimentary, construction headphones where have no electronics. They just muffle sound. They do have electronic headphones, or even individual, I should say, like for hunters or shooters or competition. They do sell these electronic headphones where as soon as the sound happens, regardless if it's for a firearm or a hammer or a drill, whatever, as soon as that loud sound hits the microphone of the headphone, it cuts that sound out and protects the hearing from being damaged by those sounds. But regardless if you're using an electronic one, you're using in the ear, or you're using just a muffled one, some sort of protection is better than nothing. Now there's different types of protection. So any store bought protection or ear protection, whether it's a plug or whatnot, whatever rating they have on that package. So say they say they attenuate 25 decibels. You have to cut that rating in half, because those are done in a factory setting. But if you get custom plugs or you get the electronic ones, they actually do attenuate about between 27 and 29 decibels. And that's pretty much the highest we can attenuate, because one thing you realize is that sound doesn't only just go through the ear, it actually vibrates through the skull as well. So sound, it can go both ways. So we only can attenuate so much without putting like a full-on helmet or something like that. But any one of those professions that definitely should be wearing some sort of hearing protection is just going to save their hearing in the long run.
Yeah. And how do you go about, in terms of protections and when being exposed to a level of noise over 85 decibels, how do you go about identify how many decibels are that, if I work in the subway or at a site that's very loud, how do you go about initially identifying and finding a piece of earmuffs that fits me?
So, and OSHA is an organization that actually governs all those occupational services. They'll give you, when you go get a job and say the subway or construction, whatever, they need to inform you of, what's going on and supply you with the protection. But if you're, say you're an independent contractor or construction where you don't have these regulations, or you're a independent carpenter or plumber or
Right.
electrician, you don't have these governors. So you have to kind of know if you're going to use a hammer and bang on metal, or if you're going to use a drill, or you're going to use a sawzall or circular saw or anything. Any power tool is going to be above the level that we're rated to hear, and it will cause damage over time. So you should always just get yourself, either go to Home Depot or Lowe's and get you those analog hearing the muffs or electronic muffs. But a way to know it, they have noise apps you can actually download on your phone, and it's a level meter. So then when you're presenting the object that's creating the noise, you can put the phone next to it and it'll give you a rating of how loud it is. So again, anything above 90 decibels, you definitely want to wear hearing protection.
Good to know. That's good to know, to kind of identify. Use the app to identify the
Yeah.
amount of noise that it does have. In regard to age-related hearing loss, what's considered normal and what isn't?
So age-related hearing loss is another term. It's called presbyacusis. So we start to see hearing loss. We can see hearing loss in about the late 50s, early 60s to late 60s. Normal is it's a hard term to say what's normal. We can see what's called a gradual sloping loss. We can see a flat loss. There are different types of losses that we can see, but regardless if it's age related, noise induced, family, genetic, whatever the case is, I do want to implore that if you do have any type of hearing loss, regardless of the cause, get yourself tested, get yourself appropriate, if need be, amplification. There are some losses that don't require amplification because the loss is very mild, or only at one frequency. So that's why a professional is very important. An audiologist is very important to have, to be evaluated by, because they can tell you whether it's something that's necessary or not. A lot of these devices now that you get online, or you have to download the app yourself and you have to figure out how to test yourself, and they're not accurate, unfortunately. That's why an audiologist is the person that you really need to go to have this have yourself evaluated. But yeah.
All right. I guess when my patients or my family members isn't listening to me, I know who to send to.
Well, the difference between ignoring or selective hearing and then actual hearing loss. A lot of people, like an argument I used to have with my wife all the time is that if I'm watching television, if I'm reading a book, I'm looking at my phone,
Yeah.
I'm focused on whatever I'm doing. And if you walk in the room and start speaking to me, it's like the whole, Peanuts, Snoopy, and that whole gang, the Peanuts gang, is the teachers going wah 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 wah. Yes, I heard you said something. Did I hear you understand what you said? No, absolutely not. So
Right.
get my attention. I'll look at you, say your piece. We'll have a conversation. But the indicator, it's like you do that. You call the person, or you shut the TV off, and you're having a conversation with them, and they're still like, "What? Repeat that. I didn't hear what you said." Or if you go out to a restaurant, there's a lot of noise where you're understanding everything perfectly fine, but your family member or friend, whatever, is leaning in, looking at your lips, asking you to repeat the things. Those are other indicators that it's time to have yourself checked.
Gotcha. And then you kind of allude on this a little bit in terms of, the role genetic plays in family in contributing to one's hearing loss. Is there a certain genetic sort of disorder or common family history that you've seen throughout your years of doing this, that these are something that you should look out for?
So yes, I've had many patients come in where either mom or dad has a hearing loss, and there's a gene that is, I don't know what the gene is, but the gene that creates hearing loss in people. I've seen it where the the patient is a carrier, but not necessarily is affected by that gene. They don't actually have the hearing loss; they just carry that gene, and that's the only way you're going to know that is by doing genetic testing. Scratch that. There's two ways to know. Have yourself tested, because genetic hearing loss has a particular shape on the audiogram. It looks like a cookie, but it's called a cookie bite. So when you take a bite out of a cookie and you see that U shape, that is 100% genetic. When we see that, we usually tell the patient, okay, this, someone in your family had to have this gene. You might want to have yourself tested, especially if you're going to have children, or if you do have children, have them tested, because you might pass that gene along to them. And the earlier you get hearing devices, if you do have loss, the better it is for you.
And is there any way to genetically modify? Is that something you've had patients? Okay.
Unfortunately, no. When you have the gene, there's no gene therapy or anything like that that can fix, not to my knowledge, that you can fix that type of hearing loss.
And then is how about the role of family history? If somebody had is there how does that play a role in terms of that if my dad had it, and that they don't have the gene?
Yep. There's a possibility. So, like I said, sometimes they're just carriers where they're not affected by the gene, but a lot of times they are affected by the gene. And again, when I see a test, and I do a test on a patient, and I see that cookie bite, I go into account mode and say, listen, someone in your family had to have had this. They passed it on to you. If you have
Right.
kids, if you're planning on kids, you might want to do genetic testing to know that this is something that you're going to be, involved with. So, but yeah, there's no way to counter it, unfortunately.
Gotcha. Things that your parents give you that you didn't ask for.
Well, the same thing like with your hair color, whether you're going to be bald or not, your eye color. These are all genes, and sometimes it's a dominant gene, sometimes it's a recessive gene, sometimes it's dominant in both parents, or sometimes it's not. And then it all depends on how it's mixed together when the child is born.
And how do you go about assessing the severity of one's hearing loss when you're doing the audiogram?
So on audiogram, there's a scale. We test the frequencies in which we hear speech, which is 250 hertz all the way to 8,000 hertz. And then we have decibel ratings. So we have 0 to 110. So the higher the number, the larger the decibel, the worse the hearing is. So, and that's how the scale. And then we test them. We produce tones, and we do also speech testing. And the higher the number in speech testing, the better they're going to do. If they have hearing loss, the better they're going to do with hearing devices. Once that speech, those speech perception thresholds or discrimination thresholds start to diminish, and they get into like the 70% and lower, hearing with hearing devices on, people are going to have difficulty. But it's going to be better than without the hearing devices. But that's how we have, mild, moderate, severe, and profound hearing losses. Those are the magnitudes of loss. And then as the scale, as we are marking the symbols, which the red circle represents the hearing from the right ear, and the blue or black X, depending on what pen you have, represents the hearing from the left ear. And we mark it on the graph, and it tells us, the severity of the loss, if there's any loss, and what frequencies they have loss in. We don't have to have loss in every single frequency. We can have what's called a sloping loss, which is usually noise induced. Or we can have a genetic loss, which again is a U shape, or it could be a flat line at a lower level. That could be age related. So, that's how the graph tells us, the audiogram tells us the type of loss that they have and the severity of it.
And then once you've identified a loss, what happens? What happens thereafter in terms of about when you consider about the possibility of a device, or at what threshold do you then recommend that? Do you make that recommendation of, hey, this is you have this hearing loss, it makes sense to kind of move forward with what your options are so that you don't.
Right. So once you're at a mild loss, And if you're at a mild loss for at least 3 frequencies, then you should counsel the patient on, the possibility of getting amplification. But it also depends on how the patient do. There's some patients I've seen who have mild loss, and they go into a noisy room and have conversations, not raising the volume on television, and they're functioning perfectly fine. And I've seen that same type of loss where people are saying, "Oh, you know what? I need amplification. I really can't hear in these situations. I'm really having a hard time." So it is depending on the person as well. It's not just because it says it on the graph, it has to be done. That's where, history comes into play. Talking with your patient, getting, to know what their lifestyle is. There's a lot of factors that go into recommending a hearing device for any individual who have hearing loss. And believe it or not, there are some people out there who actually have no discernible loss that actually do well with hearing aids, because it's just a matter of getting that sound just a little bit clearer or crisper, so their brain process the sound better.
Interesting.
Yeah. And I never believed it before, but then I actually started fitting patients myself who don't have loss, and they're coming back with like, wow, I am like unbelievable happy that now when I go into a group of people, I'm having a conversation, I'm following along what people say, and
Right.
I'm hearing them. And mind you, when you have no loss, there's not a lot of amplification given to you. It's very minimal. So it's and plus hearing aids do not cause damage to individuals' hearing. It'll depend, because they do have safety parameters built in, where amplifiers, which are like what CVS would sell, they just have a volume control. Those can cause damage because there's no regulation. You don't know the type of loss that you have, so you don't know how loud to make it. You just think you're doing better. Same thing with raising the volume on headphones and whatnot to block out other people speaking.
Right. Huh. So they have to. So they have to have been identified 3 times in a row with that. They've got to be tested 3 times in a row in order to have that
No, it's 3 frequencies that
Okay.
show a loss. That's the criteria of that was normally the criteria for counseling on someone who would to get hearing devices. But again, it all depends on how they're functioning in life, how they're functioning in noise, how they're functioning at work and whatnot. There's a lot of factors that go into it. So with knowing all these factors, that's where getting a good history on the patient comes into play, because some patients come in and say, you know what, I'm having this hard time. I'm having this, I can't understand my friends, or I hear them and it doesn't sound clear to me. And then I test them and it's like, well, you have no loss. So you could have a processing disorder, but that's a little bit different than, just not, hearing clearer. I had a patient who's in college for nursing and was having such a hard time with friends and professors and whatnot, ended up coming in, no hearing loss, not even 1 frequency, put hearing devices on them, and were astounded on how much better they're doing with the devices. So the criteria, again, if you do have 3 consecutive losses, or it varies, because some people with even 1 or 2 frequencies of loss, depending on the severity of it, can have difficulty too. So it's not cut and dry, is what I'm trying to say. There's a lot of factors that go into it, and as an audiologist, you know what to look for, you know what to ask, and you know how to counsel your patients to make sure they're getting the benefit that they need.
Right.
Again, there who have that loss at those couple of frequencies who have no issues whatsoever, and they're not having difficulty, so you're not going to fit them because it's not affecting them.
The combination of looks like you also have to look at how they're operating in terms of their quality of life, and does it match with what you're seeing on the audiogram, and then based on all that information and how they're operating outside of the clinic, whether it makes sense to make that recommendation.
100%.
Right. Great. I think these are definitely valuable informations in terms of how one goes about, and I've learned myself quite a bit from this conversation with you. I think we need to, with the wealth of information that you do have about hearings, that we probably should do a part two of this.
Happy to do so.
Love it, love it. And then we'll kind of pick up where we left off, and we'll schedule our second call.
Very good. Thank you.